Hello, everyone, and welcome to today's broadcast, Washington's New Opioid Prescribing Rules. It is presented by Blake Maresh, MPA, CMBE, Deputy Director in the Office of Health Professions at the Washington Department of Health. I am Judy O'Rourke of LabRoots, and I'll be your moderator for today's event. We're delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I'd like to remind everyone this event is interactive. We encourage you to participate by submitting as many questions as you want, anytime you want during the presentation. Just click on the Ask a Question box located on the far left of your screen and type your questions into the drop-down box that appears on the screen. Our speaker will respond to your questions via email. If you have any trouble seeing or hearing the presentation, please click on the Ask a Question box to let us know that you're having a problem. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located in the top right corner of the presentation window and follow the process to obtain your credits. Please join me in welcoming Blake Maresh. I will now turn the presentation over to him.
Thank you, Judy. I appreciate the opportunity to be here with LabRoots today talking about opioid rules that the state of Washington has just finished promulgating in pursuant to House Bill 1427 here in the state of Washington. Let me go ahead and just walk very briefly through the topic areas for today's discussion. I do want to give a little bit of background on the opioid crisis, both nationally and how it's affected us here in Washington state, as well as talk a little bit about some of the precursors to how we got to this rulemaking process. I will go through the highlights of the rules that have been adopted by our boards and commissions, as well as talk about some next steps that are going to take place in the coming months. And that will also include some of the things that we're doing with regard to education and outreach. And I finally want to end up with some takeaways, some kind of summary points about what the rules are and are not intended to do. And of course, we'll do questions and answers at the end. So to begin, I've put a slide up here on the screen of age-adjusted rates of drug overdose deaths by state. And this is nationally. This is not just opioid drugs. This is all overdose deaths. But it does give you a way to kind of do a comparative analysis about the problems that are going on with overdose in our country. Part of the reason why this involves all drugs and not just opioids is that different states track causes of death and death records a little differently. So it's not necessarily, you're not able to necessarily break out opioid-related deaths from other kinds of overdose deaths. But it does show that there are problem areas across the country, but that this is really a problem that affects all of us nationally. The next slide relates to overdose death rates, and this is specific to opioid overdose deaths in Washington state between 2012 and 2016, and it's broken up by county. Again, you can see that while there are some counties where there is a bigger problem with opioid overdoses than others, that all states or all parts of our state have a problem. They are grappling with this issue of opioid overdose deaths. One thing I would point out is that some of the counties in eastern Washington, for example, if you look at extreme southeastern Washington and Columbia County, those counties are very sparsely populated. So while the numbers of opioid overdose deaths are high, and that is reflected in a deeper red color, there are very few people in that county, and so you have to kind of take that into consideration as you think about small numbers issues. The next slide lists, it's a graphic of opioid-related overdose deaths in Washington between 2000 and 2017. And what this does is it provides a graphic representation of how we've been battling prescription overdose deaths in Washington and what some of the outcomes have been. you can see that beginning in about 2011, if you look at the blue line in the middle, that prescription overdose deaths related to opioids have actually decreased a fair amount. Unfortunately, and if you look at the lines down at the bottom of the graph, you'll see heroin overdoses and synthetic drugs like fentanyl overdoses, and those are actually increasing. They have kind of, unfortunately, made up the progress that we have had in reducing the number of opioid overdose deaths, prescription opioid overdose deaths. The next slide is a representation of how opioid overdose deaths are really just the tip of the iceberg in Washington. And I really find this presentation to be valuable because what it shows is that for every death that we had in the state of Washington, and I believe this is a 2016 number, so 694 deaths in 2016, you have 2 opioid overdose hospitalizations. You also have 21 substance abuse treatment admissions. And then down at the bottom, for every death, you have 373 people ages 12 years and older who are misusing opioids. They're using them non-medically. And I think that that's a fairly startling statistic when you think about it. So that we are certainly concerned about opioid overdose deaths, but we also have to make sure that we are focusing on the excess supply of opioids in society, because a lot of people are using them and they have not overdosed yet, and that's the thing we have to try and do, is to prevent them from overdosing. So let me talk a little bit about opioid prescribing rules and the precursors to the rulemaking process. In 2015, our state's opioid response work group, which is an interagency work group comprised of people working on various aspects of opioid treatment, came together and created a statewide plan to try and address issues related to opioid prescribing. And it's a group that's hosted by us here at the Department of Health, and we laid out a number of different goals that you can see there on the screen to try and address different aspects of the opioid crisis. We were very fortunate in that really kind of served as a initiating action for our governor, who in 2016 issued an executive order addressing the opioid crisis in the state of Washington. And you can see some of the key goals from the order here: safer prescribing practices, really expanding the use of non-opioid alternatives, and those are both pharmacologic and non-pharmacologic, as ways to treat pain. Expanding access to medication-assisted treatment, as well as increasing use of the Prescription Monitoring Program, or PMP. In the wake of that executive order, during our 2017 legislative session, there were a number of different bills that were introduced by members of our legislature, and is often the case with many big topics like this. When you have a lot of legislative activity, the legislative leadership usually finds a way to consolidate a lot of that work into a single bill, and that bill becomes the vehicle for moving forward those policy goals. And in this particular case, in 2017, the bill was House Bill 1427. And I've listed the key components to the bill over on the right. Really, it divides into 2 main hemispheres of work. And the one hemisphere is the creation and expansion of opioid prescribing rules that are under the auspices of our 5 boards, prescribing boards and commissions in the state of Washington. And then the other hemisphere of work really had to do more with expanding access to our prescription monitoring program data in a variety of ways. The other precursor I want to talk about is, in 2010, we had a bill passed in the legislature that directed those same 5 boards and commissions I mentioned earlier: the Dental Commission, the Medical Commission, the Nursing Commission, the Board of Osteopathic Medicine and Surgery, and the Podiatric Medical Board. It directed them to work together to create chronic non-cancer pain management rules by June 30th of 2011. Now, those rules at that time were limited to chronic care and it excluded both acute and palliative care. The rules included a specific limit on pain management prescribing, and if you go above that threshold, it required you to do a consultation with a pain management specialist. Now, they also provided for certain exceptions to that rule. It also, the rules included education and training requirements, both for pain management specialists and others providing pain management care, and other practice standards. The bill also required that in developing those chronic non-cancer pain rules that the 5 boards and commissions consult with the Agency Medical Directors Group here in the state of Washington, or AMDG, our Department of Health, the University of Washington, and the professional associations for each of the 5 organizations, each of the 5 boards and commissions. So moving on to the new prescribing requirements. So in 2017, in House Bill 1427, the same 5 boards and commissions were directed to adopt general opioid prescribing rules. And that included a number of exemptions available to them for things like education, training, prescribing level, patient panel, and practice environment. Again, just as with the chronic non-cancer pain rules in 2011, the 5 boards and commissions were directed to consider newly revised Agency Medical Directors Group, opioid guidelines, and CDC guidelines. The 5 boards and commissions were also authorized to work with professional associations, the Department of Health, and the University of Washington, with a goal of adopting rules by January 1 of 2019. So the department, in trying to help the 5 boards and commissions move forward on this, convened a task force, and the task force was comprised of 2 representatives from each of the 5 boards and commissions, as well as 2 ex officio representatives from our pharmacy commission. And we held a series of 7 all-day stakeholder workshops once a month between September of last year and March of 2018 in order to invite technical experts to come and provide information to our task force in order to take input from prescribers and health systems and health plans and hospitals, as well as to get input from patients and the public. And we did have a patient community, a chronic pain patient community that came to each of the meetings and were a very important part of the process. Now, the task force was not specifically authorized under 1427 to promulgate rules. So what we asked them to do was to debate the issues, evaluate the evidence, and then develop a draft set of boilerplate rules that each board or commission could then adopt or make minor modifications to and then adopt. So each of the 5 boards and commissions had to adopt their own set of rules, but those rules were heavily influenced by the work of the task force. A few exclusions to the opioid prescribing rules. The rules do not apply to any patients with cancer-related pain. And I will say that one of the areas where there is a difference amongst the rule sets is that some boards and commissions opted to say that no matter how long post-curative treatment you were still suffering from cancer pain, you would be exempt from the chronic pain rules or from the opioid prescribing rules. Other boards and commissions chose to look at it a little differently and say that if you are 2 years post-curative treatment, if you're still suffering pain that's residual from the cancer or the cancer treatment, that you can still have opioid therapy, but it would simply fall under chronic pain rules. So generally speaking, anybody who's actively engaged in cancer treatment and has pain as a result of that would be exempt from these rules. The second item where there's an exclusion is the provision of palliative, hospice, or other end-of-life care. In addition, hospital inpatient treatments are exempted from the rules, as are provision of procedural pre-medications. So the rules are divided up into a number of different phases of care, and I'm going to walk through several of these new phases where we've done new rulemaking on this slide. The first is just acute non-operative pain, and that's defined as pain during a period of 0 to 6 weeks, as well as perioperative care. And the requirements you can see on the slide include history and physical examination, screening for risk factors, intensity of pain, specifically considering whether or not there are alternatives to opioids that may be useful in lieu of just defaulting to opioids, reevaluating treatment where recovery may not be going as expected, and then follow up using objective metrics. We want to make sure that patients' recoveries are being tracked in kind of a clinically objective way. And this is for both acute and perioperative phases of care. The subacute phase, you'll see, is similar in many respects to acute non-operative and perioperative phases. The difference is that with the subacute phase, and this is not always the case, but I think in many cases it will be borne out that if a patient is progressing into the subacute phase, it may be because there is some aspect of their recovery that's not going as expected. And so what the task force and what the boards and commissions really had in mind here was that you still need to be doing the same kinds of proper treatments as you would in acute or perioperative, but you really need to stop and think about whether or not, if the patient is still not recovering as you would expect, whether or not prescribing more opioids or higher doses of opioids is indicated, or whether or not you need to take a look at some other options, such as screening the patient for any risky or aberrant behaviors, doing some biological specimen testing, or maybe sending that person to some kind of specialist, or doing some kind of consultation. Because ultimately what you want to do is you want to make sure that you're not just increasing dosages and potentially putting that person at risk for creating an addiction. This next slide lays out what the prescribing limits are for the acute, perioperative, and subacute phases of care. Now, I want to emphasize here that limits may be exceeded based on prescribers putting written documentation in the clinical record of an exceptional need. So a lower amount than the stated limit may often be appropriate for less significant pain. We really expect that these limits shouldn't typically be reached. So if prescribers should still use their clinical judgment, and if a lower amount is appropriate in order to deal with the pain, then that's the amount that it should be written for. And conversely, prescribers should not, on an ongoing basis or on a general basis, be writing exceptional prescriptions over these amounts. One of the things I will point out as you look at this table is that there's a great amount of consistency between osteopathic physicians and PAs, allopathic physicians and PAs, ARNPs, and podiatric physicians. Our dental partners are still finalizing their rules. They have one supplemental hearing coming up in December, but they have proposed combining acute and perioperative care, given the nature of their practices, that really what you're talking about when you are prescribing opioids are things like oral surgery, root canals, extractions, that sort of thing. They also have had the benefit of some additional research work done here in the state of Washington by the Robert Briek Collaborative, and that collaborative looked in recent years at dental opioid prescribing and proposed some guidelines. And so the Dental Commission has added an additional requirement that for patients under the age of 25, that you really should be limiting the amount of the opioid prescription to 12 tablets, unless there's an exceptional need, in which case you can document that in the patient record. I'm not going to spend an excessive amount of time on this slide simply because many of the chronic opioid prescribing rules remain largely unchanged from the rules that were promulgated in 2011. They are important rules, however. They stipulate things like having to have written treatment agreements with your patient, doing periodic review, and that there is that consultation requirement when your patient is being prescribed more than 120 milligrams per day, morphine equivalent dose. But there are a couple of things that have been added to the chronic section of the opioid rules. One has to do with tapering or changing a patient's prescription, and the other has to do with patients who are on high doses of opioids and when they move to new prescribers. So just spending a moment on this idea of tapering. The rules say that prescribers should consider tapering, changing, or discontinuing, or referring for a substance abuse disorder evaluation when a patient meets one of these several conditions. And there are things like if the patient requests it, if there's some kind of deterioration in pain or function, if the patient is non-compliant, or obviously if there's some kind of evidence of misuse, abuse, or an adverse event. But it's important to understand that this is really a requirement that the prescriber consider tapering or changing. It's not a requirement that people be hard tapered. So with respect to patients who are on high doses of opioids and being able to move to a new prescriber, one of the things that we heard when we were in our stakeholder workshops was a lot of fear from pain patients about what happens if my prescriber retires? What happens if they decide they don't want to prescribe opioids anymore? What happens if they don't want to do pain management anymore? What happens if they move to another state and I need to move to a new prescriber? And by contrast, one of the things we heard from prescribers is a lot of concern or fear about taking on a new patient, especially when they're on high doses of opioids. So what we've tried to do with this particular rule is emphasize that it's really normally appropriate for practitioners to just maintain dosages for brand new patients. Now, we want prescribers to eventually evaluate whether or not those dosages should be changed over time, but the rules provide a limited exemption for 90 days where you have a patient who is compliant, a patient who has been stable, they're on high doses, and they've got good pain control and good functionality. So basically, if you have a patient who has been on a stable dose for many years and they come into your office, it gives you a little bit of a window of opportunity to evaluate that patient before you decide whether or not any changes are appropriate in their treatment plan. One of the other provisions of the rules is continuing education. So all professions require now in the rules that professionals must complete a one-time continuing education requirement, and they have to do it by either the end of their first full continuing education cycle after the rules take effect, or for new prescribers that are newly licensed in their first full CE cycle. And the requirements are for 4 hours for nursing, 3 hours for dental professionals, and for medical professionals, osteopathic professionals, and podiatric professionals, 1 hour apiece. This slide just highlights several of the other provisions in the rules. As I said earlier, there is specific emphasis on alternative treatments, and really what we're trying to get prescribers to do is to consider and use clinical judgment around other types of treatments like physical therapy, massage, chiropractic, acupuncture, or even just using other kinds of non-opioid pharmacologic modalities like NSAIDs and acetaminophen, which are in some cases shown to actually provide better pain relief than opioids. So we don't want people to default to opioids as kind of the first and only treatment modality for pain. We do want to have prescribers and patients having conversations about the risks of opioids, and so we've put in there a requirement at certain thresholds during treatment that there has to be a conversation documented in the patient record about the risks of opioids, how patients can safely and securely store opioids, and making sure that they dispose of unused medications properly. And what we've actually done in the department here is, as part of our education and outreach campaign, we've provided a series of one-pagers that prescribers can use to have that conversation with patients. Now, they don't have to use it, but we've provided it as a resource for prescribers in order to help have that conversation with patients. We also have included in the rules co-prescribing requirements, and these look at not just whether or not it's appropriate to prescribe opioids with things like benzodiazepines or sedative hypnotics, where you have to kind of exercise special care because of the additive and synergistic effects of prescribing both of them together. But you also need to think about co-prescribing in the context of someone who's on medication-assisted treatment. So if they're getting buprenorphine or naltrexone and they have an acute episode or they're having breakthrough pain, how do you manage opioid prescribing with medication-assisted treatment? And certainly also, if you have patients who are on high doses of opioids, is it appropriate to do a prescription for naloxone as well? Finally, we have some special advice for certain patient populations, patients under the age of 25, pregnant women, aging populations where opioids can have a more pronounced effect, and again, acute care or perioperative care for patients who are on chronic opioid therapy. So the next couple of slides deal with required registration and checks of the prescription monitoring program in Washington. And this was perhaps the most intensely debated element of the proposed rules by the task force and by the individual boards and commissions. What the task force ended up recommending to the individual boards and commissions is a floor for safe practice. And they came to a certain set of agreements, but they also said we encourage boards and commissions, if they feel like they need to go further, to go further. And that's what happened in most cases. There is a requirement in the rules that if you prescribe opioids, and this may also sometimes include benzodiazepines or other scheduled drugs, then you have to register with the prescription monitoring program. So this slide summarizes the similarities and differences in where the 5 boards and commissions ended up with respect to checking prescription monitoring program data for the acute and perioperative and subacute phases. And I'll start over on the left and just be very brief about this. The osteopathic physicians and PAs made it very simple. They simply said, we believe that you should check the prescription monitoring program every single time you issue a prescription. So it's every script every time. For physicians, they recommended doing a check at the first acute or perioperative refill, and then at transition, so between acute and subacute and between subacute and chronic. They also recommend in their rules, or require in their rules, that where you have PMP data integrated into a health systems or hospital's electronic medical records, that you need to check it every prescription for acute or perioperative. And that's very similar to what the podiatric physicians, the second column on the right, landed on. Now, they actually said the second acute or perioperative refill, they want to align their rules with physicians, and so will in 2019 probably be engaging in rulemaking to make their requirements consistent with physicians. Similarly, on the far right-hand column, you have the proposed rules for dentists, and they've decided to, after debating a number of different positions, to align themselves with the physicians as well. So again, first acute or perioperative refill, between phases, and then if you have integrated PMP and medical record capacity, then you check every time. For ARNPs, it's just a little bit different. They said that the check should come at the first acute or perioperative prescription, unless there's some reason that you can't. And then you need to document that in the medical record. And then if you don't check at the first prescription, you need to check at the first refill. Again, between phases. And they also added a provision at the bottom that for elective surgeries, you need to check the patients preoperatively through the prescription monitoring program, or if it's a non-elective surgery, then you need to check by discharge. With regard to chronic opioid therapy and prescription monitoring programs checks, this slide kind of summarizes that for professions other than osteopathic physicians and PAs, because again, they said they wanted people to check, their licensees to check every script every time. So for the other professions, you need to employ kind of a risk stratification model where you're checking at least quarterly for high-risk patients, at least semi-annually for moderate-risk patients, and at least annually for low-risk patients. Now, of course, you should be checking if there is any aberrant behavior on the part of your patient, or again, if they're in that situation where they are going through some kind of acute episode or perioperative care, you need to be checking more often. And ultimately, the message here is that the value of the prescription monitoring program in making sure that you're providing safe care to patients is beyond question. And so beyond the requirements laid out in rule to check the PMP, we strongly encourage it. We think it's a good, reasonable mechanism to make sure that your patients are safe. It prevents, any potential concerns about drug interactions, and it also is a way to guard against the potential for doctor shopping. So in terms of next steps and takeaways, here are the next steps or the timeline for the rules. And you can see that in August and September, the 5 boards and commissions held public hearings. They had public comment on their proposed rules. 4 out of the 5 boards and commissions adopted rules, and those were finalized and submitted to our state's Office of the Code Reviser in the legislature in order to begin the process of codifying them. For 3 of the boards and commissions, you can see the final rules were effective on November 1st. So for the Nursing Commission, for the Osteopathic Board, and for the Podiatric Medical Board, all of their rules went into effect on November 1st. During their hearing, the Medical Commission stipulated a specific effective date for their rules of January 1, 2019. So their rules are final, but their rules do not take effect until the first of the year. Now, in between now and the end of the year, we've been actively engaged in doing education and outreach to try and help inform patients, prescribers, and the public about what's in the rules and what's not in the rules. And that process will continue, and I'll talk more about that in the next slide. I do want to, again, inform you that our colleagues from the Dental Commission did make some changes at their hearing in September, and so they're going through a supplemental hearing process that is anticipated to occur on December 7th. So we are still hopeful that they will have rules adopted by the end of the year. We will have to see what happens in that hearing, but hopefully in the near future, their rules will become final as well. In terms of education and outreach, we've done extensive work going back all the way to middle of the summer. And like I say here on the slide, we've been focusing primarily on prescribers, patients, and the public, but we do recognize that we have a lot of other audiences out there that we need to reach out to. And so some of our other key partners include talking with different schools and training programs around the state, partnering with the professional associations and helping provide information to them so that they can provide it out to their memberships, working with tribal communities in the state of Washington, working with other state agencies as well as health plans and health systems. And we're also making sure that we're communicating with policy leaders about the final rules and making sure that they have information that they need as well. And some of our key messages and methods for communicating out with people include doing email listserv messages. We've totally revamped our project website, and what we've done is we've put all kinds of information on the website. I'll give you the URL in a minute for that. But we were really trying to make sure that people know that they can go to the website for just about any information that they need on these rules. We've done this whole series of handouts and one-pagers, both focusing on profession by profession, what are the highlights of the rules. So we have a series of toolkits on our website, and if you are an ARNP, for example, you can go and click on the nursing toolkit, and you'll find a 4-page handout that goes into the key points around the nursing rules. And so it's customized to your individual profession. In addition, as I mentioned earlier, we've put together a series of patient notification one-pagers, and we also have those on our website. And we have a patient part of our page as well, where patients can access information about the rules. And those patient notification one-pagers are located on there, as well as a video from some of our pain management, some of our pain advocates, as I mentioned earlier, that participated in our stakeholder process. So some of the other things we're doing, we've got postcard mailers that we've sent out to licensees. We recently reached out to about 113,000 licensees in the state of Washington. We'll be doing some more later on, particularly as the Dental Commission finalizes its rules. We'll be reaching out to the dental community. I mentioned we've done video modules. So for each different discipline, each different health profession, we have a video module of about 18 to 20 minutes that goes into the highlights of the rules as well. We're doing a large number of presentations at conferences and events, and so I'm very excited that I've got the opportunity here through LabRoots to be able to provide this information to you. And we're publishing newsletter articles as well. So it's really a multi-faceted approach to trying to get to our audiences and make sure that they understand what's in the rules and what's not in the rules. So just to begin to close our presentation here, some takeaways that I wanted to leave with you. Some of the things that we've heard throughout the process, we've tried to highlight that that's not really our goal. And so some of the things that we've heard, that people are concerned about, new rules do not really make significant changes to many of the existing chronic pain rules. Those rules were modified slightly, updated a little bit, but no major changes were made to those. The rules don't set hard limits on the number of pills that can be prescribed or the number of prescription days. Again, the 7-day limit for acute and the 14-day limits for perioperative and for subacute are limits, but they can be exceeded if there's an exceptional need that's documented in the patient record. The new rules don't require that patients' prescriptions be tapered to a certain morphine equivalent dose or that people be weaned off of opioids. I talk with pain patients on a regular basis who are concerned about, are they going to see a change in their prescriptions? They're very concerned about, am I going to be able to get things to control my pain and to give me function? And the rules don't require that. And these rules don't set a trap for prescribers as well. It was very important to the task force and to the boards and commissions that people understand that these rules are there to make sure that you know what the minimum standards are for safe and effective practice and appropriate practice. But it's certainly not meant to instill fear in physicians or other prescribers that if you miss one little check or you fail to document one little thing that you're going to lose your license. This is about making sure that you're consistently doing the right things in terms of a proper history and evaluation, limiting dosages to the minimum amount needed to control pain, and providing proper documentation and doing consultation and other things when it's appropriate, as well as looking at alternatives to opioids for pain control. So with regard to things that you do need to know about what the rules do, they do allow for exceeding the stated limits, as I've mentioned, when there's a documented reason. They do promote judicious use of opioids and promote alternative pain control methods. And one of the things we went into this rule process striving to do was to achieve a balance. And there's really not three competing goals, but more of a three-legged stool. And it involves that we wanted to make sure that patients who needed opioids in order to control their pain and to achieve some level of function could still get safe and appropriate opioid therapy. So one leg was making sure the patient still could get access to opioids in a safe and appropriate way. Balancing that with making sure that we were curbing excessive opioid prescribing that leads to misuse, abuse, overdose, and death, and doing all of this while we're prohibiting or preventing disincentives for prescribers to treat patients, because what we didn't want to do was make this so onerous that prescribers didn't want to treat patients anymore. So it's really making sure that patients have access to appropriate care, that we're curbing misuse and abuse, and that we're avoiding disincentives in the system. Finally, we really think that appropriate care depends upon prescribers and patients having good communication and sharing responsibility. And that's part of the reason why we built that patient notification language into the rules as well. And again, the department offers one-pagers that prescribers can use to help facilitate that conversation. You don't have to use our one-pagers. If you want to use a different one-pager or use other information from other great sources out there, that's fine. But it is important that you have that conversation with patients. Ultimately, one of the things we heard from our advocates in the process for the pain community was that patients need you, and you need to be able to continue to treat patients with care and thought. And I thought that that was an appropriate message on which to end the presentation. I thank you for the opportunity to talk with you about our rules, and I'm happy to take any questions. I have provided for you on this last slide here the URL for our project. It's www.doh.wa.gov/opioid prescribing. And we've located on there kind of a summary of the process that we went through to complete these rules. You can find the rules language on the website, as well as all of our education and outreach materials. And with that, I will turn it back over to Judy.
Thank you, Blake, for that informative presentation. We'll now start the Q&A portion of the webinar, and we'll address some of the most commonly asked questions by our viewers. So if you have any questions you'd like to ask, please do so now. Just click on the Ask a Question drop-down box located on the far left of your presentation window. Type your question into the box that appears on your screen and click the Send button. Our speaker will follow up with your questions via email. So let's get started. Our first question is, regarding the chronic pain rules and tapering, are prescribers required to taper patients?
So that's an important question, because some of what I've heard from pain patients is that out of fear or out of not knowing what's in the rules, prescribers are starting to try and forcibly taper patients. The rules only require that physicians or other prescribers consider tapering in that very defined set of circumstances. So again, if a patient requests that their prescription be changed or tapered, then that would be a time to do it. If there is some kind of evidence that the patient is engaging in aberrant behavior or risky behavior, or there's been some kind of an adverse event, some kind of an overdose, then it's important that the prescriber really reconsider whether or not that patient needs to continue to be on that level of opioid therapy. But again, it does not require that prescribers forcibly taper people, and it does not require that they taper them to any particular level as well. So I know there's a lot of confusion around the 120 milligrams per day morphine equivalent dose, and I've had people say, do I have to get all my patients to 120 MED? No, you don't. So I appreciate the question. It is something that we want clinicians to use their best judgment on, but they do not have to taper patients.
Okay, thank you for that. The next one is, do prescribers have to document the results of the prescription monitoring program check in the patient record?
They do, and this is also kind of a good question that I've gotten from people, and they've asked, do I have to actually run the check, and put it in the patient record? And the answer is that's certainly one way that you can document that you did it, is to actually incorporate the check into the patient record. You don't have to, however. And it's important also to know that while the prescriber is required to review the prescription monitoring program check, they don't have to run it. So within Washington's system, if you're the prescriber, but you have if you're a physician, for example, and you have a nurse or a medical assistant who works for you, you can go into our PMP and you can designate those other staff to run checks on your behalf. And it's perfectly appropriate under the rules to have a medical assistant or a nurse run a check for you, but you have to review it, and you have to document in the record that you did review it. And again, that can be as simple as making a note that check was done on this date, and here's what I observed, or you can actually incorporate the report into the record. But that part is really up to the clinician and what they want to do. So yes, it is required to be documented, but there are a variety of different ways that you can achieve that.
Okay, we have time for one more question. Are practitioners still required under the new rules to seek a pain management consultation when patients in chronic opioid therapy exceed a daily morphine equivalent dose of 120 milligrams per day?
They are. That particular provision in the rules has not changed from the 2011 rules that were promulgated by the 5 boards and commissions. So if a patient is on a dose, is a patient undergoing chronic opioid therapy, and they're on a dose of opioids exceeding 120 milligrams per day, morphine equivalent dose, then there is a requirement that the prescriber have a pain management consultation with a pain specialist. Now, there are certain provisions in the rules, and those have been, again, they've been there since 2011, that are exceptions to that requirement. And some of those exceptions relate to the patient. So if the patient, as a prescriber, if you make good faith attempts to reach out to a pain management specialist and you're not able to connect with someone, and you document those in the patient record, then and your patient needs continued opioid therapy, it may be appropriate then to go forward and continue to treat that patient at that level above 120 milligrams per day MD. There are also some requirements, or some exceptions in the rule that relate to the prescriber. So if you complete a certain amount of CE, you can, and you're just a treating physician or a treating clinician, you can be exempted from the consultation requirements. So there are very specific education and experience requirements to be a pain management specialist. But you separately can meet a more limited number of continuing education requirements if you're just a treating practitioner. And that education and experience will give you the ability to treat patients without having to go and get a pain management consultation. But absent going to those extra steps of getting that additional education, yes, the existing requirement that a pain management consultation occur at over 120 milligrams per day MED still exists in the rules.
Well, thank you for that. I would like to once again thank Blake Maresh for his presentation. I would also like to thank LabRoots for making today's educational webcast possible. Before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through February 15th, 2019. You'll receive an email from LabRoots letting you know when this webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's event. That is all for now. Thank you for joining us. We hope to see you again soon. Goodbye.